Welcome back, everyone, to the Wilson Science and Technology Forum. Today, our speaker is Josh Jacobs, who is at the Rush University Medical Center in Chicago. Josh served as a chair of the Department of Orthopedic Surgery for 16 years. He also served as the vice provost for research at Rush and is currently the Granger director of the Rush Arthritis and Orthopedics Institute. Josh is also a past president of the American Academy of Orthopedic Surgeons and of the Orthopedic Research Society. He currently serves as the president of the Board of Trustees of the Orthopedic Research and Education Foundation. In sum, Josh has distinguished himself as an educator, as a researcher, as an administrator, and importantly, as a noted orthopedic surgeon. I should also mention that Josh is a prominent member of my personal extended academic family at MIT. This is a group I really do treasure. So, Josh, and I guess I should say we are happy to have you with us today to speak about 5 decades of orthopedic biomaterials research lessons learned. It's good to have you here, Josh, and good to see you again. The floor is yours.
Well, thanks so much, Ron. It's really an honor to be amongst this incredible group as I hear your backgrounds. I have a bit of a Boston connection. I did 4 years of my medical training in Boston at the Harvard Combined Program. And I had a 6-month research elective where I worked in the H.H. Uhlig Corrosion Laboratory at MIT, and my mentor there was Ron Latannison. And one of the prizes that I had for my residency in Boston is I met my wife, a girl from Milton and Randolph. And so we really do have, our family has tremendous Boston connections. So I'm going to take you through a little bit of a journey here. The first thing that I hope you ask yourself is, how is it possible that he's talking about 5 decades of research? Because I know I look old, but I don't think I look that old. But here's the reason is that my first paper was actually published in 1976 in the Journal of Endodontics. And for those of you who don't know what endodontics is, that's root canal, something I wouldn't wish on my worst enemy. Nonetheless, I was an undergraduate material science student at Northwestern at the time, and I was in a cooperative engineering education program. And my co-op was actually as a researcher in the biomaterials department at Northwestern University Dental School. And there was an issue at the time with a fracture of these files that were used to extirpate the canal when you're doing a root canal, the dental pulp. And if you turn them counterclockwise or you backed off, they would sustain a brittle fracture. So we investigated that. It was really a kind of biomaterials 101. It was a heat treating process. Nonetheless, this is how I got my start, and my mentor at that time was Eugene Lautenschlager. So I've been doing biomaterials research since my undergraduate days, and I've seen a lot of things come and go. And so that's the basis for this talk. In the medical field, we always list our disclosures because of potential conflicts of interest. And was mentioned, I'm the current president of the Orthopedic Research and Education Foundation. I've had research support from a number of commercial entities. Currently, Zimmer Biomet, which makes orthopedic implants, does support research programs at my institution, Rush. I've also had NIH funding. I may in the future get royalties from a company called Signature Orthopedics for a design of a knee replacement, and have these other things, none of which are particularly relevant to the content of this talk. So what I thought I'd do is look at this 50-year history as a case study of an implant system that did not do well. And I think I should just take a step back, because many of you have had joint replacements or will have them, or your loved ones have them. And I think it's fair to say that total hip replacement has been the greatest advance in the treatment of osteoarthritis in the last century, or any end-stage disease involving the hip. It's a very successful procedure. Over 500,000 are done annually in the US alone, and it has a very high success rate. Nonetheless, I'm going to talk about failures because we learn a lot about our failures, because it allows us to design implants that will last longer and longer, work better, and the history of joint replacement is such that that over time we make incremental improvements to make the systems work better and better. So what you see here on the left is a metal on metal bearing, and a hip replacement consists of a socket component, which is fits in the acetabulum, which is part of the pelvis, and the femoral component, which goes in the femur or thigh bone, consists of a stem that goes down the canal of the femur and then a head. And so the femoral head and the acetabulum articulate with one another. They're meant for motion. And so on the left, you see a metal on metal bearing total hip replacement design in the 1960s. It's a McKee-Ferrar implant that was produced in England and Norwich. In the center is a more contemporary metal on metal bearing total hip replacement that was very popular in the 2010s. And on the right is a metal on metal hip resurfacing, where you don't see the stem on the femoral component, but instead it's a ball that goes on top, or it really just caps the femur. It preserves femoral bone stock. So these are the devices I'm going to be talking about, none of which are actually commercially available now. They've fallen out of favor. But understanding why these implants failed, I think, gives us particular insight into the field of hip replacement and how we can move forward using new technology to make the operation better and better. So why am I talking to you about implant systems that are no longer in use today? Well, Shakespeare might have said it first the best in The Tempest. He said, "What's past is prologue." Another way to frame it is quoting the philosopher historian George Santayana, that those who do not remember the past are condemned to repeat it. And of course, a modern quote from an amazing statesman, Winston Churchill: "Those that fail to learn from history are doomed to repeat it." So in our field, it's really critically important that we understand what we used to do, why it was abandoned, why it didn't work, so we don't repeat those mistakes. And as long as we're talking about great philosopher poets, I thought it would be nice to talk about one of my favorite, Donald Rumsfeld, former Secretary of Defense, actually was a wrestler at New Trier High School here in Chicago before he went on to college. He actually said this quote during the run-up to the first Iraq War. I'm not making this up. He said, as we know, there are known knowns, there are things we know. We also know there are known unknowns. That is to say, we know that there are some things we do not know, but there are also known unknowns. The ones we don't know, we don't know. So this is a fun tongue twister to try to repeat here. But I want to point out there's kind of a kernel of genius in that, and this is concept of the unknown unknowns, the things that we don't know that we don't know. And in my field, in adult reconstructive orthopedic surgery, it's these unknown unknowns that have come back to haunt us over the years, where we see that failures of some of the designs that we've come up with are related to the fact that there are things we don't even know we don't know. And so uncovering those has a great benefit to our field. So I'm going to frame this in terms of 9 lessons, and I'll try to get through this in the time we have allotted, that are of kind of a different scope and things that I've learned over the years that I think are informative and how we can make things better going forward. The first lesson I learned the hard way is that the orthopedic device industry and the orthopedic surgery profession at large are in the crosshairs, particularly with the media, and we can't afford a repeat of the debacle of this failure of metal on metal. So many of you may remember this. This was in the early 2010s. And these metal on metal bearings were becoming more and more popular for reasons I will explain shortly. But they were not working well. And there were weekly or sometimes even daily stories in certain publications about the failures of these implants. Now, this happened to occur at a time where I was the president of the American Academy of Orthopedic Surgeons, which is a 30,000 member organization that really leads the profession. So at the same time that I was working in this area scientifically, I was also the spokesperson for the profession. And I found myself talking to Barry Meyer of the New York Times, who would do regular articles on this. And it was particularly painful for me in our profession because the storyline that Barry Meyer in the New York Times was pursuing is that these implants that were failing dramatically were the result of an evil cabal between orthopedic surgeons, the FDA, and greedy industry. And of course, it couldn't be farther from the truth, but that was the narrative that was being put upon us by the media at the time. And you know, what you do professionally, you do not want to be associated with the facial expression of the woman on the right. But this is what was happening at the time. It was really a tarnish in our profession. And of course, you know you're really in deep trouble when you make it to network television. And I don't know if you've ever watched the show House. I never have. I cannot, as a physician, I cannot watch medical shows. It just doesn't work for me. But one of the episodes of House, it turns out that the mystery diagnosis that he at the last minute figured out, someone was dying of a cobalt intoxication from her metal on metal bearing implant. So when it gets to the general public in that fashion, you know you're in trouble. So I think that what we learn is that we are quite exposed, and the orthopedic implant industry and our profession cannot afford to have these massive failures. What we're talking about is a system where, and I'll explain to you the kind of results we saw after introduction in the early 2010s. We saw a very high failure rate. The second lesson that I think is very important, we need a U.S. joint replacement registry. So what is a registry? Why do I say that? Well, a registry in medical devices is where every patient who gets implanted with a certain device or certain technology or categories of technology goes into a database where there's all sorts of information and demographics and details of the procedure, et cetera, that can be monitored in real time to determine how these devices are performing. There are very robust registries for joint replacement overseas, particularly in socialized medical countries such as Scandinavia, Sweden, Denmark. The UK and Wales has a very robust joint replacement registry, in Australia. All these are socialized systems where the government can actually capture all of the data. It's very challenging in our fragmented medical system in the US. The closest we can come is the Medicare database, but that only captures individuals primarily over the age of 65. So we do need a systematic joint replacement registry in the US so that we can understand how our devices are performing in real time. Now, why do I say that in this context? Because when metal on metal bearings were reintroduced in the early 2000s, and again, I recall that the technology was originally introduced in the 1950s and 60s in the UK and lost out to the competing technology of the low friction arthroplasty, which is a metal on polyethylene bearing. When this was reintroduced, multiple published studies showed that that device was performing favorably from 2 to 5 year follow-up. But in our business, in joint replacement, we really are looking for a solution that lasts decades so that we don't have to go back in and do a revision or replace the original joint. That's what our patients want. That's what we want. But eventually it became known, there were some isolated case reports that things weren't going as well as we had hoped, with some reports of osteolysis, which is a fancy term meaning bone loss, aseptic loosening, where the implant will become loose, and other sorts of soft tissue reactions to these implants in a small number of patients. But it wasn't until we really mined the UK joint replacement registry that we understood how bad the problem was. In other words, we were seeing failure rates of certain devices of up to 40% at 5 years. That's a massive failure rate, where at the time the standard bearings, and you can hang your hat on the fact that maybe the failure rate is 1% per year. So maybe at 10 years, you're seeing a 10% failure rate of the conventional bearings at the time. And here we were seeing a 40% failure rate at 2 to 5 years. So clearly something was very, very wrong with this system. And understanding why this happened will inform us going forward. One thing we learned is that the surgical technique and the design of the implant really matter. This should seem axiomatic, but we do have evidence of it, and it really strengthens the individual that surgical technical parameters are critical. We have to educate our surgeons on how to put these implants in properly, and also understand those factors of the implant design that is under the control of the manufacturer that can lead to these outcomes. So what we learned is there's this critical parameter called the contact patch center to rim distance that determined how these metal-on-metal bearings were performed. So this is a tribological construct, and you can see that the whole idea, and some of you will understand this tribology, others may not, but tribology is a study. Tribos is a Greek term meaning rubbing, and tribology is the study of rubbing, the science of rubbing, friction, lubrication, and wear. And whenever you have any engineering applications where two surfaces are supposed to rub against one another, so obviously a joint replacement is an example of that, but also a piston engine and many other engineering applications, how these materials perform in terms of material loss and heat generation, et cetera, become very important for how the engineering system behaves. So it turns out that in these systems, if the contact patch, which is in blue, overlaps with the edge of the acetabular component, the socket component, that leads to a phenomenon called edge loading, which results in a tremendous amount of wear and excessive or accelerated debris generation. And as we'll learn shortly, it's the debris generated from the implant that was determining the biological response of the local tissues and ultimately the bad results. So this contact patch to rim distance, if it was within the contact area and not within the edge of the component, it turned out that that dictated the performance of the device. Now, as you can see, that can be related to the hemisphericity of the acetabular component. It can be related to the clearance, which is the difference of the radius between the socket and the head, and also related to factors involved in lubrication and how the implant is inserted. If you insert the acetabular component so that it's vertical, or in my terms, to abducted, that will promote edge loading. And in the other plane, it would be the degree of anteversion, or how this is related to the coronal plane or the sagittal plane of the pelvis. So how you place the implant, how it's designed, determines how much propensity there would be to edge loading and how much debris that might be released. In fact, this contact patch to rim distance is really a critical factor to understanding the individual performance of the device, as pointed out by one of the pioneers in the field, Dr. Harlan Amstutz. But edge loading is not just an issue with metal-on-metal bearings. It turns out that it's an issue with any hard-on-hard bearings in hip replacement. And just to take a step back, the typical bearing surfaces that we use currently and historically have been a hard-on-soft bearing, meaning some kind of hard material such as a metal or ceramic on the femoral side, and on the acetabular side, it would be a polymeric material. And where we are currently is the polymer that we use is a highly cross-linked, ultra-high molecular weight polyethylene component. We got there through trial and error through many decades. And this system of hard on soft is currently the standard of care and behaves very well. However, we've looked at hard on hard systems for a variety of reasons, some of which I'll cover shortly. But when you have a hard on hard system, in this case, a ceramic on ceramic bearing, with edge loading, it can be susceptible to something we call stripe wear in ceramics. This is an alumina ceramic material, which is commonly used for the femoral head in total joint arthroplasty. So again, this is related to the tribology of the system and also the position of the acetabular component. Edge loading is a major factor, as is the surgical technique. Lesson 4 is a lesson of hubris, that we didn't know as much about implant failure mechanisms as we thought at the time when we were designing these implants in the late 90s. So let me take you back to where we were. When I came out of my training from Boston, and I did a fellowship in Chicago and ultimately stayed there because it was a center for joint replacement, what I would see in my clinic in patients that had hip replacements was not too far down the line, particularly high demand patients that were very active in using their implant for physical activities and were still in the workforce, et cetera, is this problem of periprosthetic osteolysis and aseptic loosening. Now, it's a medical term. Periprosthetic simply means around the implant, around the prosthesis. Osteo means bone, lysis means dissolving. So the bone around the implant was dissolving, bone loss around the implant. And then by virtue of this bone loss, the implants were becoming loose, and aseptic means it was becoming loose without an infection. Because if you have a periprosthetic joint infection, that can also lead to loosening. And that infection occurs in about 1 to 2% of patients that have a hip replacement. But this was a common presentation of patients. They didn't have an infection, but they would come back, and you can see in that lower left x-ray, you can see a fair amount of bone loss on the femoral and acetabular side, showed as radiolucencies where there should normally be bone. And this was driven, we thought at the time, by debris generated by the bearing surfaces, where the femoral head would rub on the acetabulum. And the upper center is the metal on polyethylene bearing surface at the time. It's a cobalt chrome molybdenum alloy, and at that time, an ultra high molecular weight polyethylene component. And that debris, which you can see in the center, lower center, if you look at tissue, and this is for our pathologist, if you look under polarized light, polyethylene debris is birefringent, and you can see this debris within the tissue leading to a foreign body reaction, and in some cases, actually a highly inflammatory reaction, which I'll show you shortly, dominated by lymphocytes. So we thought the biology was such that debris generated from wear would interact with local cells called macrophages. This is what the immune system, how they would respond to debris generated from their bearing surfaces, and then initiate a whole cascade where after phagocytosis, where the debris would come intracellularly, this would cause elaboration of pro-inflammatory cytokines, and this inflammatory reaction would interact with bone cells, such as osteoclasts, which cause resorption of bone, and osteoclasts would be turned off, so there'd be less bone formation, more bone resorption, leading to this osteolysis. So this is the way we understood this cascade, and that was driven by the volume of wear debris, the volumetric wear, meaning the amount of wear debris per unit time. So the rationale then for these metal-on-metal bearings, and also at the time we did introduce other bearings such as hard-on-hard bearings made of ceramic materials, was that we would decrease the volumetric wear that was generated in comparison to the metal on polyethylene bearings at the time. And also because of the mechanics of metal and the mechanical properties of metal implants, we could put a far thinner acetabular component. We have to have a certain thickness of a polyethylene acetabular component or it'll wear through. But for metal, which is far more wear resistant than polyethylene, we can make a much thinner acetabular component so the femoral head can be larger, and that would make it so that the hip was more stable. It wouldn't dislocate. By using larger diameter femoral heads, the hip was much less likely to dislocate, which is also one of the failure mechanisms of total hip replacement that was common at the time. So the volumetric wear rates that we're talking about are for the conventional polyethylene that was in the late 90s or late 80s and early 90s. It was a volumetric wear rate of about 100 cubic millimeters of polyethylene per year. And the competing technologies introduced at that time to reduce that wear rate were ceramic on ceramic bearings, metal on metal bearings, and also highly cross-linked ultra-high molecular weight polyethylene, where there was purposeful cross-linking with electron beam or X radiation, and then subsequent annealing or quenching to remove the free radicals. And you can see that depending on the technology you're using, there would be dramatic reductions in the amount of volumetric wear. In the most for ceramic on ceramic, factor of four orders of magnitude, or maybe 1 order of magnitude for polyethylene. So these are the competing technologies at the time. We thought that by reducing volumetric wear rates, we'd solve the problem. Well, it turns out it didn't work out for metal on metal. And why is that? And I would posit to you that the reason is it has to do with the biology of the debris that's generated from the metal on metal wear. Because not only do metal components wear from the mechanical and the tribological interaction between the two surfaces, metal components uniquely undergo a process of corrosion. And then there are synergistic interactions between corrosion and wear, causing mechanically assisted electrochemical processes, which we call tribocorrosion, things such as fretting corrosion and mechanically assisted crevice corrosion, both of which are very important in the performance of the devices, as we'll see. So the degradation products coming off from these degradated processes included particles from the wear process, but also free metallic ions from the electrochemical reactions whenever these ions would complex with in the local tissue, for example, proteins forming colloidal organometallic complexes, or perhaps inorganic metal salts or organic storage forms. So to understand how the body is going to react to these implants, you have to understand the bioreactivity of each of these different moieties in terms of the local cell and tissue response. So what do we know about metal particles? One of the things we learned when we looked at tissue that was retrieved from individuals who had metal-on-metal bearings, some of them very successful, as you can see that some of these components were in situ for in excess of 20 years. If we look at the periprosthetic tissue and use a transmission electron microscopy, we find that most of the particles are actually nanometer in size. There's a large size range. Most of the particles are less than 50 nanometers. And given that the mean particle size for polyethylene is about 10 times that, 500 nanometers or 0.5 microns, that even though the volumetric wear rate may be 1 to 2 orders of magnitude less with metal-on-metal bearings versus metal-on-polyethylene bearings, actually the number of particles generated can be 1 to 3 orders of magnitude higher depending on what the mean particle size is. So it begs the question is what dictates the bioreactivity of the particles? Is it the number of particles? Is it the size of particles? Is it the surface area, the aspect ratio? Is it the surface configuration? All of these things are what I would call nanoparticulate biology that we're just really scratching the surface of. It's very difficult to study nanodebris in biological systems, and these are still in the category of unknown unknowns. We didn't understand this at the time that these implants were introduced, and we still have an incomplete understanding of this. But it's this nanobiology that really is dictating the reaction of cells and local tissues to this nano debris that's going to be dictating the biological response. Now, one of the consequences of this very large number of very fine particles, less than 50 nanometers, is that there's an enormous specific surface area, defined as the surface area divided by weight. And the reason the surface is important is that's where the particle, it's on the surface that there's interaction with the local environment, either the periprosthetic fluids or the cells. And the greater the surface area, the greater the interaction with the environment. So one of the consequences of this very large specific surface area is that you can measure metal ions or metal debris. It could be nanoparticulates, they could be ions, not only in the synovial fluid, but also in the serum of patients. And this represents studies we've done at Rush over many years. This was an NIH-funded study where we prospectively followed a number of individuals that had different types of joint replacement. And to summarize this complex slide, the normal value of serum chromium in individuals who are healthy, normal renal function, and don't have an implant is about 0.3 parts per billion or nanograms per liter or micrograms per milliliter. So that's the unit we use, parts per billion. But if you have a conventional metal on polyethylene bearing, and that's in these boxes here, you have maybe a 2 to 4-fold increase. But if you have a metal on metal bearing, and even if it's well functioning, you may have a 10 to 20-fold increase in the amount of metal that we're measuring in the serum. And even for this group of patients, this is a group of patients who've had implants for an excess of 20 years. So these are the best of the best. Metal on metal bearings that are continue to perform. Even they have dramatically elevated metal levels even 20 years after their implant. So that begs the question, what is the biological or toxicological consequences of having these elevated metal levels for decades? And I will get to that. And this is an unanswered question. This is true for serum chromium, serum cobalt. Again, these are cobalt chrome alloys. We know, and through a number of studies we've done in our lab and elsewhere, that at the right concentration, cobalt, chrome, molybdenum ions, and we studied chlorides here, can elicit pro-inflammatory cytokines. This is interleukin-1 beta, which is known to be a very pro-inflammatory cytokine that we study because it could be associated with this periprosthetic osteolysis or bone loss, inflammatory bone loss. This is also true for cobalt chrome aluminum alloy particles. So both the particles and particulate and ionic debris can be associated with this inflammatory elaboration of cytokines that can lead to inflammatory bone loss. And at higher concentrations, these metal ions can actually kill the cells. This is a study looking at cell toxicity, and at somewhere between zero point 0.1 and 1 millimolar, and you can get concentrations as high with a failed cobalt alloy prosthesis. Cobalt in particular can lead to cell death. And why am I presenting inflammation and cell death in these cell studies? Because that's what you see histologically, and I will show you a slide of that shortly. Now, this is also this nanoparticulate biology is also important for polyethylene particles because we find that this highly cross-linked polyethylene wear debris, which has dramatically reduced the wear, by the way, and in the race between ceramic, metal, and highly cross-linked poly metal bearings, this one has won out. So that in 2026, highly cross-linked polyethylene bearings are the standard of care because they have far lower wear rates by virtue of this highly cross-linked process. However, their particulate debris from the highly cross-linked polyethylene may be a factor of 2 smaller than the polyethylene debris, such that, and there's some studies that suggest that this smaller debris may be more bioreactive. This is an elaboration of TNF alpha, another pro-inflammatory cytokine. So there's this interaction between the number of particles and the individual bioreactivity of particles that has to be taken into account so that we may not be out of the woods yet with wear debris causing issues, particularly for the knee. For a variety of reasons, we cannot cross-link the polyethylene in the knee to the same extent as the hip. The knee is a far more complicated joint. There are stress risers in the normal design of the components, such as posts or dovetails, that we have to be mindful of because in the process of highly cross-linking the polyethylene, not only do we improve the wear properties, we change the mechanical properties, reducing the fatigue crack propagation resistance and to some extent embrittling the polymeric material. So there's this interplay between particle size and bioreactivity that we have to take into account. Another lesson that I learned is how important corrosion is in implant failure. And I'm so grateful for my background in corrosion engineering that I got not only as an undergraduate and material science major, but also in Professor Latannison's laboratory at MIT. Why do I say this? Well, if you look at the tissue around failed implants, the chrome to cobalt ratio is reversed. In the alloy, the ratio is about 1 to 2, whereas in the periprosthetic tissue, it's 9 to 1 or 5 to 1, depending on how you're measuring it, either atomic absorption or inductively coupled plasma mass spec. So what's actually in the tissues are not wear debris, it's a corrosion debris. So it's either corrosion products from the nano debris that are there or potentially precipitates from the metal ion coming off of the surfaces that complex with salts or local proteins that leads to this corrosion debris. We've learned a lot about the potential bioreactivity of corrosion debris. This is another situation that's not a metal-on-metal bearing per se. It's a metal-on-metal contact area. It's a modular junction of a cobalt alloy on a cobalt alloy femoral component. This is the head on the neck. And if there's any micromotion there or fretting between the head and the neck, it can generate this debris that we see here. You can see it here, and resulting in this massive osteolytic lesion in the periacetabular region of the pelvis. You can see that hole in the bone. This patient came in the mid-90s. He was totally asymptomatic, had no pain, even though he had a hole in the bone. If that hole progresses, or as that progresses, that will eventually lead to loosening and failure. The pelvis will fracture if it's got a big hole in it. And so we obviously want to intervene before that happens. And it turns out that it wasn't polyethylene wear, it was actually wear from the corrosion debris. Here it is histologically. You can see this greenish tint that turns out to be that is very present in very fine particulate debris, and you can see this with backscattered scanning electron microscopy. Here's an individual histiocyte or macrophage showing the submicron debris that we showed with spectroscopic techniques to be a chromium orthophosphate. We've actually looked at these particles in cell culture. This is an in vitro model of periprosthetic osteolysis where we use rat skulls and we sprinkle particles on top of them. And using calcium-45 release, we determine the amount of bone loss. And these corrosion particles turn out to be very stimulatory and can cause periprosthetic bone loss similar to other fine debris, including polyethylene. And in this system where there's no polyethylene, and no bone cement. So the only particles generated in this system, which is an intramedullary rod to treat a femur fracture, this was a modular stainless steel nail. You can see this periprosthetic osteolysis associated not with polyethylene or bone cement, but actually with corrosion debris from this stainless steel rod and this modular connection. The idea was if you had a modular nail, you can minimize inventory and save on costs. Well, it worked in terms of healing the fracture, but it caused other problems with periprosthetic bone loss. So what we didn't know at the time we introduced the metal-on-metal bearings, we did a lot of hip simulator studies, but we only looked at the tribological or mechanical aspects of the interaction between the surfaces. We essentially ignored the electrochemical interaction, and it's really this combined mechanical and electrochemical or tribocorrosion system, which is an integrated approach to study the performance of metallic surfaces. We didn't do it at the time, and we suffered the consequences. Because had we done the appropriate preclinical simulatory steps, we would have understand that tribocorrosion could be an important failure mechanism to the device. Here's a tribological or a tribocorrosion type system where you have a ball on flat where you measure not only the material loss, but also you measure associated currents. And so the implication of this was to enhance the predictive value. Preclinical testing of metal bearing surfaces should include tribocorrosion testing in addition to the standard tribology simulations. We are challenged in our field because we can't run a clinical trial to see how an implant's going to perform in 15 or 20 years. It's just not practical. So we need to have predictors or surrogate endpoints so that we can study implants to try to predict how they're going to do. I would call this regulatory science and how we can come up with biomarkers that can ultimately predict performance. And we're not there yet in orthopedics, and we need better predictive testing, better modeling so that we can adequately predict how a new system is going to perform in 5, 10, 15, 20, 25 years. Ron, I just want to do a time check. When do I need to wrap up my comments here?
Well, we typically end around 12.
Oh, okay. Oh,
Yeah.
wait, that's an hour and a half. For me, that's an hour and a half, but for you, it's a half an hour. All right.
Yeah.
So I'll wrap this up in the next 10 minutes, okay?
Good. Perfect.
All right. So lesson 6 is that we need to better understand the systemic effects of metal debris and ask your patients about their general health. Now, why do I ask this? Well, it turns out that cobalt and chrome are essential trace elements. We have to have them for normal health. It turns out cobalt is an essential component of cobalamin, vitamin B12, which is a very important cofactor in DNA and fatty and amino acid metabolism. Chromium, likewise, is essential because it's important in how we process carbohydrates and how we process insulin. And normal blood levels are about, as I mentioned, about 0.3 parts per billion. So they're essential elements, but if they're in toxic, they are toxic when they're in excess. And what we've learned from certain occupational and accidental exposures is that, for example, in mining, grinding, and alloy industries, that excessive cobalt can lead to various downside toxicities, including lung fibrosis, polycythemia, which means you have too many red blood cells, which can lead to problems in blood flow and hypercoagulability. Neurological impairments, including visual and auditory impairments, hypothyroidism, and cardiomyopathy or heart failure. Chromium likewise is associated with very high levels with certain downside effects, including lung cancer. And you may recall the Aaron Bronkovich story, which was all about hexavalent chromium causing cancer. We believe, fortunately, that most of the chromium degradation products in the human body from joint replacements are the trivalent form, which is not as carcinogenic. Now, there are some cases where metal levels can get quite high and lead to very dramatic toxic effects. And if we search the literature for this, we found out that they're very rare, but they are very severe. We see them, for example, not only with metal on metal bearings, but also in a situation where you have a failed ceramic bearing. So if you have a fracture of a ceramic, at the time of revision, you can remove a lot of the ceramic debris, but some of the ceramic debris, essentially glass, stays behind. And if you replace the head, for example, with a metal head, it can lead to disasters like this, where the ceramic debris erodes. This used to be a sphere, and you can see all the metal that's been eroded. And what can happen in this situation is that the mean blood cobalt levels can be dramatically elevated. Remember, the normal value is zero point 0.3. So this is 4 orders of magnitude elevations in serum blood levels. Now, these are very dramatic cases, and they can present with very dramatic findings such as blindness, deafness, peripheral neuropathy, heart failure, necessitating heart transplant. Now, fortunately, this is very rare. So we're talking about far less than 0.001% of cases result in these very severe kinds of acute toxicity. But here's one example of it, of a 33-year-old who had a hip resurfacing of metal on metal in the mid 2010s. He had a large head, and he reported this very young guy. And when he was 40, in 2018, he was diagnosed with cardiomyopathy, with low ejection fraction, left ventricular ejection fraction, which should be, greater than 60 or even 70 for a young patient. His cobalt levels were quite high. He was chelated, and then he was revised. The cobalt levels went back toward normal. You can see 4 parts per billion, and his heart recovered. You can see his ejection fraction is far greater after this. So this is real cobalt cardiomyopathy. And on the retrieved implant, you can see this edge loading wear pattern showing a high wear situation, and the histology reveals some particulates in the tissue and an inflammatory reaction consisting of moderate lymphocytes and neutrophilic infiltration. In the joint capsule, you can actually see cobalt chrome debris. These are rare cases, fortunately, as I mentioned, but the question is, what about low-level chronic exposure? Is this going to cause some chronic toxicity? And there are some indications in some literature that there are some subclinical changes in heart function in patients with metal on metal bearings. Patients are not symptomatic, but perhaps their hearts aren't functioning as well as they could be in the absence of these high cobalt levels. Myocardial levels are elevated in the setting of total hip arthroplasty. We've seen in autopsy studies, and we've also done a study showing that there may be some subtle effects on the heart. So this is an area where we don't know as much about as we'd like, but it's something we certainly want to have a surveillance of our patients. And this is hot off the press. Can these metal particles cross the blood-brain barrier? It turns out they can. We've shown this for cobalt chrome debris, also for titanium alloy debris. In most hip replacements and knee replacements, one of the components is made from titanium. This we just reported in this journal Acta Biomaterialia. And we looked at this issue in some depth because we have an Alzheimer's Disease Center at Rush that really does an amazing job of getting patients, following them longitudinally, and having their brains to look at after death. So we correlated the patients that had joint replacements with findings of Alzheimer's disease, measuring metal levels in the brain and looking at Alzheimer's histology. And what we found was that patients with total joint replacements had significantly higher cobalt within the brain, mainly driven by total hip replacement. And across all samples, cobalt was positively correlated with AD pathology, Alzheimer's disease pathology. And so, fortunately, there was no correlation between cobalt and cognitive decline. So we're left with this situation: was what impact do these metals have on the brain long term? We don't know. Hopefully, they're not causing cognitive decline, but they do get to the brain, and this is an area we need to understand far more in far more depth. So cobalt and chrome are essential for health. High-level exposure can lead to very severe acute clinical deficits, but clinically significant acute toxicities only there with very high cobalt levels. but the prevalence of chronic toxicity from decades of exposure is really unknown and leading to a high index of suspicion. I'm going to skip lesson 7 in the interest of time. This is a very complicated area. You can see I'm mercifully not going to go over this with you, but the immune response is quite important. And the reason I will say that is that a really important finding from Hans Willard, a pathologist and an orthopedic surgeon, was that there's a unique histology associated with these failed metal-on-metal bearings that he terms ALVAL, aseptic lymphocyte-dominated vasculitis-associated lesion. This is for our pathologists, where there's a peculiar type of histology that looks like a delay type hypersensitivity reaction, but really isn't. So there's some interaction between the immune system and the debris that we don't fully understand. And the second to last note, and this is for the material scientists here, is that we can probably do better in this area if we understand the mechanistic basis of why our implants are corroding. We found that on some retrieval studies that a tribochemical reaction later is present on some of the successful devices. And in fact, if this could be stabilized, this can serve as a solid state lubricant. So pursuing this with some colleagues at Northwestern, Laurie Marks, using TEM techniques, we found this carbon-rich zone turns out to have this pi peak, which means that there's a graphitic solid-state lubricant that can be associated perhaps with decreasing this amount of metal release from this tribocorrosion reaction. So if we could come up with strategies to stabilize this tribofilm, this might be a way to minimize the amount of debris generation. And through other studies using, for example, quartz crystal microscopy, molybdenum, which is an alloying agent here, may be essential to form this tribochemical reaction layer. So the implications of this is that there can be novel strategies to improve metal surface tribocorrosion performance. So metal-on-metal bearings may be used in the future to take advantage of their benefits. But right now, the way we stand is that we really have struggled with dealing with the biological consequences of the metal debris released from these devices. And the final lesson that I will mention is, and it's kind of an obvious lesson, is that we as orthopedic surgeons, and perhaps us as medical consumers, that's all of us on this webinar, we need to be circumspect about the adoption of new technologies, because sometimes the latest and greatest isn't the best, particularly when there's no track record. So with that, I will thank you for your attention. It was a very long-winded discussion, and I'll be very, very happy to answer any questions you have about this topic or about your arthritic knee or hip or even your bad back. So thank you.
Josh, thank you very, very much. Obviously, this is a subject of interest to everybody on the planet. Frankly, we're all aging. Nobody's growing younger. And these kinds of problems occur and not unlikely. And I think it's important for us to be alert to what you spoke about. Now, I just have an observation and a question. I have a very good friend, lives in California. Hadn't seen him for a couple of years, but the last time I saw him, previous time, he was limping badly, very much in pain. Then I saw him again just before Christmas this past year. He'd had a hip replacement and he was an absolute joy. He could walk, he could literally run, he felt perfect. I'm just wondering it's obviously been very successful for him, but what is the prognosis? Is it like, I don't know the details of the hip replacement materials, but I just wonder what your experience is with current replacements and the sort of performance prediction going forward. What
Sure, thank you. It's a great question. And as I intimated during my talk, we started this field in the 50s and 60s, and we did a lot of trial and error. And the initial bearing material that was used was a polytetrafluoroethylene, or Teflon. And this was a pioneer in the UK. His name was Sir John Charnley. And he did about 250 of these in very elderly, low demand patients. And of the 250, about 240 failed, and the ones that didn't fail had died before they failed. So that was the first foray into artificial hips with the metal on polyethylene bearing. But through
Yeah.
trial and error, we identified better and better materials. So that the materials available to us in 2026, this highly cross-linked ultra-high molecular weight polyethylene, with a ceramic head, alumina zirconia composite ceramic head, and a titanium alloy stem is giving us survivorships currently of 95% at 15 to 20 years, which is a
Yeah.
tremendous advance
Yeah.
compared to when I came out of my training in the late 80s.
Yeah.
Now, the question is, and because we're doing these implants in people that may have life expectancies far in excess of 15 to 20 years, if
Yeah.
you get a joint replacement in your 40s or 50s, you may need this for 4 to 5 decades.
Yeah.
Question becomes, can we rely on the current materials to persist at 25, 30, 40 years? I doubt it. The Achilles heel has always been wear and tribocorrosion. And so the question is, we need to continue to iterate to improve our materials so that we can meet this demand, or alternatively, look at biological solutions. So, for
Right.
example, regenerative medicine, tissue engineering, replacing with actual native bone and cartilage. We are far away from that yet, but something that we would like to work for in the future. So, for those of you on the call that need a hip replacement, if it's done by a good surgeon with good technique, using aseptic technique, with a highly cross-linked polyethylene on alumina zirconia ceramic bearing, you can anticipate that the results are going to be excellent for 15 to 20 years and maybe beyond.
Good. We have questions. So thanks, Josh. Let's go to Albert.
Hi, Joshua. Very nice presentation. My wife recently had a knee replacement, and her doctor told me it was titanium on a plastic. And I haven't heard any titanium from your talk. Can you clarify that when you talked about metal? Is titanium part of what you folks use in the hip?
Yes, I didn't focus on it, but right now, as I mentioned, the standard hip replacement includes a titanium alloy stem, titanium 6 aluminum 4 vanadium alloy stem, and with an acetabular component that is a titanium alloy acetabular component, or it could be tantalum or titanium alloy or a commercially pure titanium surface on it. That's standard. Now, I doubt that your wife, she might, but the typical knee replacement, the femoral component is a cobalt chrome molybdenum alloy, and the tibial component is a titanium alloy with an ultra-high molecular weight polyethylene insert. It's unlikely that he used titanium alloy for the femoral component unless he used the titanium nitride component, which is available. So we tend not to use untreated titanium alloy components in bearing surface applications because it is not as good a bearing as cobalt chrome alloy. But yes, I'm sure your wife has a titanium alloy tibial component that is with a modular polyethylene, ultraviolet polyethylene insert.
Well, I'm glad the doctor did the right thing. Another question. In your tribology, you mentioned the mechanical effect and the corrosion effect. Now, there's also electrical effect in tribology,
Yeah.
triboelectric charges. Does that come in at all in your case?
Yeah, well, yeah, I think the corrosion is electrochemistry. So yes, it does. I mean, by tribocorrosion, the study of tribocorrosion involves, the marriage of electrochemistry and tribology. There's a colleague of mine, Jeremy Gilbert, who's really a material science, but he's also a real expert in electrochemistry, who has looked at some of the electrical aspects and the effect of the electrical currents on surrounding cells. And there are some interesting issues of cell toxicity from aberrant currents. So that's something that I think you're right, that that's an interesting insight, that the electrical aspect of it has probably not been fully investigated in terms of its local effect on cells.
Okay, and one last comment on you mentioning using Teflon years ago. Now, Teflon, now we know, contains PFAS. So
Mm.
I'm very happy that they're not putting it in, otherwise, people would have these forever chemical in their knees and hips.
Well, that also brings up the issue of microplastics, right? And so
Right?
everybody's very, very, laser beam focused on microplastics now. They're finding them everywhere in the body. They're finding them in coronary plaques. They're finding them in organs, in the brain. We've been dealing with microplastics in orthopedic surgery for decades because microplastics are generated by our implants. And they still are. So, if you will find microplastics around every joint replacement that is done in the US. The question is, can you keep it at a dose, at a level below a threshold that where there's a biological reaction to it? But we're now working. For example, we're working with the Great Lakes Council because the Great Lakes Council in my area is very concerned about microplastic contamination of the Great Lakes. And we're working with them because we have a novel technique of how to identify microplastics in tissues using Fourier transform infrared spectroscopy imaging, FTIR imaging, to find these nanometer-sized plastic debris. And so that's part of the issue is to identify the debris and then figure out what the biological reaction is. But that's a very important point is that orthopedics might be able to contribute to our understanding of the impact of microplastics writ large.
Good. Let's go
Very
on to
good.
Eddie.
Thank you.
Thank you, Albert. Eddie?
Yes, I actually did my PhD in triboelectric charge transfer. And in those days, we had quite a bit of theoretical work being done. None of it was really quite correct, but it dealt with Fermi levels between materials and so forth. And came across quite a number of different issues in industry. For example, chocolate factories that exploded as a result of stainless steel in contact with chocolate powder. And another where a pub, basically the stainless steel tubing corroded under an influence of a certain specific type of beer. So, but what I'm getting at, I guess, is that there are many instances of or information, perhaps, that relate between materials and biological materials, if you will, where corrosion and so forth has occurred in the past. And maybe there's a source of information there that might be useful. But speaking, I'm just wondering if there are any lab experiments that people have been performing in relation to these materials. Part of the problem often is that there are also trace impurities that lead to also rapid corrosion and so forth. And I wonder if you've made comment on some of that. I myself have a titanium annulus in my heart, keeping my mitral valve open, and plus a pacemaker, whose material I'm not even sure of. So I'm also wondering about these kinds of things over long periods of time.
Yeah, so for the latter point, just, I want to re-emphasize a point that I tried to make earlier. The current generation of engineering materials used as biomaterials have evolved in some cases through trial and error, in some cases through theoretical work, but have evolved to the point that they are in general very safe and effective. And that includes not only orthopedic devices, but cardiovascular devices as well. But again, with time, they may wear out. And in an application such as a joint replacement, where you may need decades of function, it behooves us to really optimize the materials to get that from them. And that's why we do need continued advancements in material science to produce better implants. In terms of the impact of different impurities, I don't think that's been identified in our area as a source of accelerated degeneration. Where it has become an issue is in this old concept of metal allergy. And this is a very troubling area, and I didn't get into it during my talk because I just didn't have time to cover it. There are many patients who believe that they are allergic to their implants, and there is a plausible mechanism of metal-induced allergy. For example, you may know that some individuals, actually 15 to 20% individuals in the general population, may have a contact dermatitis to a metal jewelry. So
Yeah.
some of you may find that if you put a watch on, a Wendell watch band, you get a skin reaction. And this is more common in women because they're more common to wear metal jewelry. Women often have reactions to their earrings and their earlobes, etc. So it begs the question: well, if their skin is sensitive, what about the deep tissue? Would they have a reaction to the metal debris that comes off of their implant? Even some metal impurities, for example, nickel, which is
Mm.
the most common allergen for contact dermatitis. There is what I would call trace nickel. It's less than 1% in the cobalt chrome alloy. So does the trace nickel that's present in cobalt chrome alloy, which is present in 95, 98% of total knee replacements, can that lead to metal allergy? And it's highly debated. The nickel that's present is it's trace level. It's not bioavailable because it's tied up in the alloy. And so this becomes a very challenging clinical conundrum for us because it's very difficult to assess clinically. So this whole area of metal allergy is one that we really need to work out, and it's by extension, it's an area where we need to understand the immunological reactions to our implant debris in far greater detail to understand how we can improve uh, that process for patient care.
Thanks,
Thank
John.
you.
Michael.
Thank you. I appreciate your talk. Uh, Chemistry is not my best aspect of knowledge, but let me ask you this: Is I understand in friction is one issue that you're dealing with metal and metal. On the corrosion end, has there been any work done, or is it viable to consider using oral or intravenous uh, 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 therapies to reverse the corrosion, hydrogenated water, ionized water, those types of things that I'm reading about? Can that have any impact that would be helpful? And number two, you mentioned back, asked about back. Well, I'm getting to the point where walking is becoming difficult. My next MRI is Wednesday. If you were me up here in Western Massachusetts, and I'm willing to drive a distance, would you recommend somebody that I should talk to?
Yeah, so let's start with the first point. And could you repeat it for me? It was regarding using
Yeah,
intravenous.
whether there's some type of a therapy that either oral or injectable, intravenous, that can help reverse or prevent the corrosive aspects of this, ionized water with hydrogen. Is it in that area? Does that make any sense?
Yeah, it could. However, you got to worry about the toxicity, particularly and some, various organs may not be so appreciative of some of these compounds that can affect corrosion. They may have severe biological reactions. So clearly, you'd have to study the biology. And I would think that rather than deliver it systemically, you would want to deliver it locally, either with an
Mhm.
intra-articular injection or perhaps even better with some sort of treatment of the implant,
Oh, I
with
see.
some sort of a coating that can
Hmm.
have some sort of durability. And
Hmm.
that's why I mentioned this whole tribochemical reaction layer. Is there a way that we can pre-treat the implant so that it forms a solid state lubricant
Hmm.
to
I see.
minimize any tribochemical reaction? There
Hmm.
is nothing on the horizon that I'm aware of where there's a systemic treatment to minimize corrosion. You
Okay.
can give chelating agents to minimize the amount of metal in the system in the biological system, but that probably is not going to affect the corrosion properties.
Thank
And
you.
yes, I think that what I would suggest to you, and I'm a fellow back pain sufferer, is that the first physician you see is not necessarily a surgeon, because
Mhm.
most back pain will resolve in 85% of patients, acute back pain will get better no matter what you do. So I would see a specialist in back disorders who's not necessarily a surgeon. In our practice, we have physiatrists, individuals who are trained in physical medicine and rehabilitation, that are spine specialists that can provide all sorts of diagnostic and non-surgical therapeutic interventions that may help you. But surgery can be very effective if none of that other stuff works. But I would start with a non-operative spine specialist.
Thank you.
Just a comment. Your question about reference to someone who might help reminds me of an interesting part of Josh's history at MIT. I used to have students who played rugby on weekends, and every weekend after they finished their games, they would be beat up. You know, their legs would be sore, they'd have cuts and bruises and twisted ankles and knees. And I would come into the lab on Monday morning, and Josh would be in the lab with these guys sitting on lab benches, and he'd be twisting their knees and trying to understand whether they really have a problem or it's treatable or whether it's not a big deal. He's always been in demand, and he continues to be in demand. So,
Well, orthopedic surgeons love rugby. It
yeah.
keeps our offices filled. The other thing we love is pickleball,
Oh,
particularly pickleball for guys our age,
oh, yes,
Uh,
yes, yes.
it keeps our offices very full.
Okay, let's go. We have two more questions. Let's go on to Avi.
Very enjoyable talk. Thank you. You touched it briefly. I guess the holy grail here would be some kind of artificial cartilage or something that would regenerate the cartilage. You don't have to replace the joint. I assume we're somewhat far off with regard to that. I'd like to ask about the shoulder joint. It seems to me intuitively that because it's not a weight-bearing joint, at least not like knees and hips, that the tribology problem would be reduced. Why do, if they, what's the failure rate with shoulder joint replacements? And because it is less weight-bearing, why do they fail? And another question, if you were coming across a patient who doesn't need 20 years, an older person who, if you give him 10 years or even 5 or 6 years, that will last him for what amounts to the rest of his life. Would that alter the consideration of the materials or the technique in terms of the joint replacement?
I'll start with the second one first. A great question, and yes, we have as orthopedic surgeons we do perhaps select different types of materials and bearing couples depending on the patient demand. So someone who's very active, for example, if they have a disease process in their 30s that results in degenerative changes in their hip, we may be more likely to use a hard-on-hard bearing, such as a ceramic-on-ceramic bearing. The idea being is that that's the most wear-resistant material. However, there are some downsides of ceramic-on-ceramics, which I won't necessarily get into. Um, but in general, I think the standard of care is no matter what the age, is a ceramic on polyethylene for a hip replacement at least, a ceramic on polyethylene, and I think we'd probably still use the same types of materials. For an elderly patient who maybe has a hip fracture and otherwise is quite ill and may not have more than 5 years to live, you can put a metal ball on, a cobalt chrome ball, but most of us are using ceramics. As for shoulders, yes, it's not a weight-bearing joint, but there's still high joint reaction forces generated by the muscles. So, and it might be, the amount of force may be similar, although not to the highest extent as a hip or a knee. And total shoulders fail by similar mechanisms, aseptic loosening, wear, and there's probably tribocorrosion. And we don't have as long of experience with total shoulders, but we in our implant retrieval lab are getting more and more of them, and we're seeing similar patterns of degradation that we see on hip replacements. What's unique about the shoulder is the scapula or the glenoid component. The glenoid is a very small piece of bone. That's where it would be the equivalent of the acetabulum in the hip. It doesn't have as much bone as a hip. It's more demanding in terms of how you position the components. And a lot of failures in shoulder replacements have to do with glenoid loosening, and it may have to do with the quality of bone in the glenoid. I'm not a shoulder replacement expert. The way our field is parsed now is that you're an expert in hip and knee, And if you do shoulder replacements, that's kind of a different specialty. But my understanding from my shoulder colleagues is that the Achilles heel of the shoulder is the fixation on the side of the glenoid, the scapula.
Thank you.
Pete, you have the last question today.
Ron, I can't find a way to raise my hand. Could I ask a final quick
So
question?
I have a question here. I'm sorry.
Yeah,
Oh,
Tom,
I'm
Tom,
sorry.
go ahead.
Please,
Go ahead.
Yeah,
for me.
Yeah, go ahead, Pete.
yeah. I'm waiting for the injection on my knee, so I don't have to have a bone or knee replacement. How close are we for a bone on
Yeah,
bone, no cartilage left?
I think that we'll never get there when you're bone on bone of an injection. Injections may be effective early on in the process. So what we need to do as a specialty is we need to identify osteoarthritis long before you can see it on X-ray. And that's an area where I think that it's ripe for investigation to identify early biomarkers such as cartilage degradation products or type 2 collagen. Type 2 collagen is the most prominent collagen in cartilage. Type 2 collagen degradation products. And then in turn, once we identify it in earliest stages, come up with a way to reverse the pathophysiology of cartilage deterioration, which in fact causes the vast majority of osteoarthritis. There's an interaction between bone and cartilage, however. It's a complicated process, osteoarthritis. We do not have a disease-modifying osteoarthritis drug, a DMODE, that actually alters the natural history of osteoarthritis. We do have DMARDs, disease-modifying arthritic anti-rheumatologic drugs. So these DMARDs have totally changed when you have inflammatory arthritis leading to end-stage joint disease. There are drugs that can prevent that. We would like to get that for the more common form of osteoarthritis, most common form of arthritis, osteoarthritis. So we're very far away from an injection or a pill. Hopefully, in the next 10 to 15 years, there will be candidate agents. Right now,
Yeah.
the
So for me,
solution
it's just a knee replacement, is what
is a
you're
knee
telling.
replacement when you need it, and when you need it, it's very effective and can
I've
transform.
already had one. I know the
There
deal.
you
It's
go.
brutal. I know the deal.
Thanks, Pete. I lied. We're going to have two more questions. Let's go to Tom first and then John Brown. Tom, go ahead.
My apology to Peter Baldwin. He was agreeing with the speaker, and I thought it was his question.
Okay. Okay.
I understand that one of the healthiest things we can do as we age is going out for an hour walk every day, spiritedly. Am I in danger of wearing out my cartilage?
Probably not. And I say probably because I haven't examined you, and it depends on your alignment and all sorts of things. But one of the compelling reasons to actually get a joint replacement when you can't walk is to actually improve the rest of you. And there's more and more information now that individuals who have end-stage degenerative arthritis of their hip and knee who do not get joint replacement, it tends to exacerbate other chronic diseases such as cardiac disease and pulmonary disease. So it's important that those individuals get joint replacement so that they can be more mobile and do what you do and exercise and walk. What I would say is that walking is a great form of exercise, but there's other great exercises such you can so-called cross-train. And I really encourage my osteoarthritic patients to swim because swimming is a way that's a great workout for your aerobic, your cardiovascular workout. It works the upper extremity muscles. It's important to reverse the potential effects of sarcopenia as you age. Sarcopenia is muscle loss. It's important to do some kind of some not only aerobic but also some weight training exercises. So swimming works the upper extremities. You're buoyant in the water, so you're not lowering the lower extremities, but it is working the lower extremity muscles. So a combination of weight-bearing activities such as walking and non-weight-bearing activities such as swimming is a really good way to keep your health.
John, go ahead. You have the last question. Go ahead. Oh, you're muted, John. You're muted.
Um, I wondered, you didn't, I don't think you covered it all in it. Over the decades, has there been advances in sort of robotic assistance of the surgeons when they're putting the components of the replacements together so that they fit better? And if so, has that made much difference in survival of the replacements?
Yeah, great question. Yes, robotics is starting to really become a big factor in this kind of surgery. It's been around for a while, and it's becoming more and more popular. And what the data shows us now is that robotics is associated with better alignment of implants, both hip and knee. In other words, there are fewer alignment outliers. And by alignment, I mean whether the knee is straight or a little crooked, bow-legged or knock-kneed, varus valgus is the terms we use. And so you seem to have far fewer outliers with robotic total knees. However, a clinical benefit has not been demonstrated. So, but again, we're talking about situations where we're looking for results 10, 15, 20 years. And the question is, if you have a better aligned knee, will you have better results at 15, 20 years? And we don't know the answer to that yet because we haven't had a robotics around long enough. Robotics is now the standard of care in many surgical disciplines. So if you have a prostatectomy or what have you, it might be done with robotics. It is not the standard of care yet in orthopedics, largely because it slows down the surgeon and the clinical benefits are really unclear.
Okay, Albert, I lied again. You have the last question. Go ahead. As long as it's quick. We need to
Very
let our
quick. I want to respond to Peter Baldwin's question, but I want to say it in front of Joshua so he could keep it. Correct me if I'm wrong, but I had my knee bone on bone some 25 years ago. And a guy in my tennis group said, take glucosamine, chondroitin, and it did marvelous things for him. So I've been on it ever since. And then more recently, the physical therapist showed me some exercises that strengthen the upper and lower sides of the knee without putting any effort on the knee, and I've been surviving. Now, I haven't checked my x-ray again to see what happens, but I survived 25 years plus with knee on knee, bone on bone knee.
Yeah, and what I'll say to that, and I'm not going to give a long-winded answer here because I know we're getting late here, is that points to a really important issue is that there's no necessarily correlation between the radiographic appearance with the knee and the amount of pain you're experiencing. So we have individuals with bone-on-bone arthritis that don't have a lot of pain, and vice versa. We have individuals that have what we could consider moderate forms of arthritis that have a lot of pain. So there's a major focus now in studying the pain associated with osteoarthritis. What is driving the pain? It may not be the arthritis itself. It may be other factors that have more to do with neuroanatomy and neurophysiology than the actual joint deterioration itself. So stay tuned for that. I think we're going to have novel understandings of pain going forward. That is another way we can deal with osteoarthritis.
Josh, thanks for that response. Before I let you go, I just have an observation that I want to make, and then with loud applause. But you mentioned the materials research has often been one of trial and error in terms of prosthetic materials. And I just want to mention that we've had several speakers as part of our program who've spoken about a program called the Materials Genome Initiative. It's a nationwide effort on behalf of computational materials science and engineering that really has changed materials education and practice dramatically. Now, I recommend it because I think a lot of what you're talking about it's a theory-based process by which you put together a theoretical model and then and then generate potential materials that may perform the role you're looking for. And then you test them. And it's been very, very productive. I think it might be helpful in terms of prosthetic materials. So that's the first point. Then an observation. I keep thinking, I know we've talked about this before. I keep thinking that nature has been pretty smart in choosing ceramic materials for bones and joints and so on. And I just wonder whether or not um, if you took the Materials Genome Initiative and did it properly, the computational process, and asked it to survey and help identify ceramic materials with the right chemical properties, structural properties, mechanical properties, and so on, it might actually be helpful. And I just think MGI is something to really help in terms of the path forward for materials that might be beneficial for prosthetic materials. So that's just a suggestion. It's something I hope you and I ought to talk about that. I really think it could be beneficial, and I'd enjoy having that conversation.
Yeah, and I do agree with you. I think our talk was, can do better than nature?
Yeah,
And that I don't know.
yeah,
But if it could approach how well nature, cartilage and bone is an
yeah,
unbelievable material that evolved over 2 million years.
yeah,
And it is incredibly specialized tissue that performs miraculously.
yeah.
Can we reproduce that or do as well as that, or at least approach it? I hope so. And this Materials Genome Initiative, boy, I welcome it. That sounds like a real great opportunity.
Deal. We're on. Well, I'll be back in touch. I want to thank you for this talk today. It was wonderful, absolutely wonderful stuff. You can tell by the questions and the interest of this group, and it's a larger group typically, and I think a lot of people maybe they were frightened of hearing about something that concerns them. I don't know, but this will be recorded. It will be broadcast in town. It will be made available to anyone who wants to look at it on YouTube or on our website.
The
I have,
holiday weekend.
yeah, that could also be part of it. But I just want to thank you, Josh. This has been a wonderful presentation. I'm just so glad that you're part of the medical research team that's involved with prosthetic materials because your experience is absolutely vital. So thank you so much, not only for myself but for everyone else.
Well,
Thanks,
thank you
Josh.
very much. It's been an honor. What an amazing group of people. And have a wonderful weekend. And
Okay,
feel free to reach out to me if you have any additional questions. Joshua.jacobs@rushortho.com.
okay.
Ron knows how to get in touch with me, so I'd be
Yeah,
happy to discuss anything further.
thank you. Everyone, take care. We'll meet again in 2 weeks. Take care, everybody.
Take
Have a
care.
good weekend. Bye-bye.